there are actually at least 4 different types of PCOS, and it's gotten much more complicated.
It really comes down to what works for you and how better you can adhere to it.
Welcome, Lyle, for the second, well, I think it is going to be the third episode because I broke our first one into 2 blocks, and this one is going to be the third one. We covered quite a lot last time on everything about women menstrual cycle, stubborn body fat, fat loss in general when it comes to cellulite and doing certain adjustments. But this time we want to cover PCOS, and if we can possibly talk a little bit about menopause. I think it is a really important topic that tends to be a little bit forgotten sometimes.
Okay, absolutely.
Awesome. So with PCOS, Lyle, what is PCOS? The definition has evolved over time and now seems to be called as a metabolic condition rather than a hormonal condition. Maybe you could delve a little bit deeper into that.
So polycystic ovary syndrome, just for background, it is, I believe, the most common reproductive disorder in women. When it was originally discovered, and this was back in described back in the 1930s, they presented a case study of patients that had 3 things. One was cysts on the ovaries, right? Polycystic, multiple cysts on the ovaries. They showed elevated testosterone levels, and they showed menstrual cycle dysfunction, either a lengthened cycle, it's called oligomenorrhea, which is a cycle every 35 to 90 days, or full-blown amenorrhea, where there was no menstrual cycle, which ends up being that women with PCOS don't ovulate. So that was the original description. And for decades, that's what it was. And actually it was originally called Stein-Leventhal syndrome. Those were the 2 physicians that described it. And then over time, PCOS kind of became the better descriptor. Now in the modern era, there are actually at least 4 different types of PCOS, and it's gotten much more complicated. There was a conference in Rotterdam, and this led to what's called the Rotterdam criteria, which is the most commonly used diagnostic criteria, right? So the 3 criteria for PCOS are multiple cysts on the ovaries, and that is found by ultrasound, by an OBGYN. Elevated androgen levels, and androgens are things like testosterone, DHEA, androstenedione, there are a couple of others. That can be determined by blood test or by clinical manifestation, things like oily skin, acne, increased body hair. Small percentage of PCOS women may lose hair like male pattern baldness, and menstrual cycle dysfunction, either oligomenorrhea or amenorrhea. So those are the 3 criteria. The way the Rotterdam system does it, if you have 2 or more of those 3, you have PCOS. And what this leads to is 4 different types, right? You can have all 3. You can have multiple cysts on the ovaries, elevated testosterone levels, but not have menstrual cycle dysfunction. You can have no cysts on the ovaries. And I realize that that's very confusing. How can you have polycystic ovaries and not? But you have elevated testosterone and menstrual cycle dysfunction. And you can have multiple cysts, no elevated androgen levels, and menstrual cycle dysfunction. So there's 4 different types, and this is, I think, what you're getting at, that it's still all called PCOS, but I think there's a little bit of a push. I think within the next 10 years, they're going to call these different things. Right now, it's just subtypes 1, 2, 3, 4, and the negative effects are worst if you have all 3, least if you don't have elevated androgen levels, and I forget what 2 and 3 are. So it's kind of now this broad term that describes these different things. And, so there is a lot going on. And really so far as the metabolic consequences, I think what you're getting at, one of the most commonly seen things with PCOS is insulin resistance, which means that their bodies don't respond to insulin properly, which means that when they eat carbohydrates, blood sugar goes up, insulin goes up. It has a number of negative effects. Something like 60 to 65% of women with PCOS are insulin resistant. And if they gain excess body fat, that goes to like 95%. So it's for all I have a feeling that 4th group that doesn't have elevated they probably don't show insulin resistance for reasons I might get into. But for all practical purposes, women with PCOS, one of the hallmarks is insulin resistance. Now, that can lead to a number of other things, including the development of diabetes, the full-blown metabolic syndrome, which is that whole cluster of diabetes, elevated blood sugar, elevated blood pressure. There's a whole cluster of things. Those are extremely common. And while PCOS might not cause them, they predispose women to develop that. There's also frequently PCOS is associated with carrying excess body fat. Now, there's a little bit of debate in the research, right? There is a lean type of PCOS. And I suspect it's that fourth group, that subtype 4. And I think that tends to be a little underrepresented in the research because if you're a woman with that type of PCOS and have no symptoms, you don't go to the doctor, right? This is my speculation. I suspect they're not being seen clinically because they don't think there's anything wrong, because there's nothing severely wrong. Same thing with the overweight. Some researchers think that that's being overestimated because if someone has PCOS and is not carrying excess body fat, they don't go in for help. They don't go to diet study. They don't go to diet groups. So, but this doesn't change the fact PCOS and weight gain are commonly associated. And there's a number of reasons, and there's a whole bunch of other stuff that goes on. Mostly negative, right? I mentioned some of the clinical manifestations: oily skin, body hair, acne. There are increased rates of anxiety, depression with PCOS. And it may be like brain chemistry, it may be biological, it may simply be a consequence of being female and either carrying excess body fat, having excess body hair, feeling unhappy with yourself. There's sexual dysfunction, which may be related to that, just due to a sense of self-attractiveness or sexual self-worth. And realize as a male, I'm not the one to comment on this. This is what the research says, so please don't mishear me. Binge eating disorder is much more common, and that may be part of what's driving the excess body weight on top of everything else. So there really is. Yes, please.
So when you say that binge eating and depression can be one of the things that you see a lot in PCOS women, do you think that especially like binge eating and these behaviors could be potentially aggravated or potentiated by the fact that there's so many fallacies in nutrition, and like, do you have to go keto, you have to completely eliminate carbohydrates, you have to go completely vegan and clean eating, otherwise you can't just be healthy?
I honestly, I think that contributes to almost everybody's neurosis. Actually, I did a consultation last night, and she is overwhelmed because everyone is like, oh, you have to do intermittent fasting, you have to do keto, you have to do paleo, you have to do this. And she's like, I don't know who's right. And I go, well, me, because I'm the one you're paying. And I kind of, when I told her, I'm like, look, none of that matters. What matters is long-term adherence, sufficient protein. Everything else depends on you. But yeah, I think that absolutely is part of it. When PCOS women are looking for solutions, they're being told 100 different things from 100 different people, frequently being based on whatever someone is selling. Unfortunately, that's just, rather than what the research is. So there's this whole cluster of things, pretty much negative, all negative. And there is one positive I should at least mention. Most of that, and honestly, the fertility, right? If you look at fertility clinic statistics, especially for anovulatory infertility, when women are not producing an egg, PCOS women represent 80% of the women going to fertility clinics for anovulation. That's how massive an effect it is. And for women who want to have children, that will contribute to the depression. That will contribute to their anxiety.
Yes.
If what you want to do is have children as a personal choice and you can't, I mean, again, as a male, I don't have any real, I can understand it intellectually, but I can only imagine what that does to a woman's mental state. So this is all huge. This is all a huge part of it. Now, those are the negatives. There's one potential positive worth mentioning, which is that PCOS women, especially if they have elevated testosterone levels, make great athletes. And what you see is that at the highest level of elite sport, PCOS women are vastly overrepresented compared to their percentage. In the general population, somewhere between 5 and 20%. I've never seen two people give the same numbers, and it depends on how it's being diagnosed. But in elite sport, it's seen 30-40% of female athletes, because those elevated testosterone levels tend to make those women, they build muscle more easily, they have higher bone mineral density, they're more aggressive, they pick more intense workouts, they tend to be found in strength power athletes like swimming, sprinting, things of that nature. So there is one potential advantage, but that also comes with all these negatives, right? So like, I think one of the things we talked about in the first podcast, we'll probably touch on again with birth control, right? Whether or not PCOS is good or bad depends on what you're trying to do. From a health standpoint, it can be very negative. Fertility standpoint, absolutely horrific. If you're trying to be an elite athlete, it can be a fantastic advantage.
You could say that like women would be stronger, like perform better in these regards.
Oh, absolutely. So to put it in perspective, so the normal range of testosterone for women is 30 to 70 nanograms per deciliter. I can only think in American units. Some PCOS women can have double that. They may have up to 150. Now that's still below, a man's low normal is about 300. So it's still half of that. But comparatively speaking, if you double a woman's testosterone levels, she will have a significant advantage. They're stronger for the amount of muscle mass they have, gain muscle more easily, higher bone mineral density. There's a number of advantages. And like one study even was like, you know, should PCOS be considered a doping condition, like taking anabolic steroids? And I don't think so. That's a separate argument for others to have, but it is a huge advantage.
It would be positive to kind of, at least for women that are so depressed about their PCOS, at least, well, you actually could be doping.
Yeah, in a strange way. So like I said, so that's very context dependent, but I think mainly, you know, focus on those negatives, what we can do about them. So to your point, it is sort of being, I think, reconceptualized as a metabolic disease because of all these metabolic consequences, a lot of which have to do with those elevated testosterone levels. That's one of the big keys to that. Although what you see happening is elevated testosterone causes insulin resistance. Insulin resistance leads to high insulin levels, which raises testosterone levels, which causes insulin resistance. So there's this cycle, and it's hard to sometimes figure out like what's causing what, but in a way, it doesn't matter, right? Because what we'll talk about when we look at treatment, when you address either one of those, if you lower testosterone levels, insulin resistance goes down. If you lower insulin levels, testosterone levels go down. So it's sort of, in a sense, it doesn't matter which is the cause, but they are severely, severely interrelated.
There's one misconception that I think it is important to clarify. A lot of people say that like PCOS has a genetic component, but there's like an environmental factor that could trigger PCOS as itself. So is it obesity? Is it weight gain? What is it that is affecting or like triggering the development of PCOS? What is your thoughts on that?
It's a really good question. There are a whole bunch of different sort of theories floating around. There is absolutely a genetic component. And one of the more interesting things, they're now starting to examine a PCOS type in men. There is sort of a semi-equivalent condition, and women with PCOS, their brothers, far more likely to have it. So there's absolutely a genetic component. Okay. However, there's some thought, there's been a lot of real interest in recent years about hormone exposure during fetal development, right? Like when if the baby is exposed to high levels of testosterone, that affects physiology. That may be involved. So there's genetics, there's hormonal exposure. Then there's what happens sort of early eating habits, gaining weight. But then the question becomes, what's causing what, right? If one aspect of polycystic ovary syndrome genetically is insulin resistance, is appetite control. And that's something I even forgot to mention. PCOS women's bodies don't regulate appetite as well in terms of ghrelin and all the gut hormones. They don't respond to them as well. So the question then, and I don't think anyone has an answer to this, and I certainly don't, is it that little girls who gain weight, that triggers the PCOS? Or is it the underlying PCOS that causes them to gain weight that makes it worse? Because there is no doubt that everything that PCOS causes, like the insulin resistance, is made worse by carrying excess body fat. I don't, at least, and I looked into this fairly recently, there's a lot of speculation, and I don't think anybody's quite sure. But I mean, one thing in this regards, when they look at adolescent female athletes that are performing at the high level, they still see markers of PCOS. So I tend to think it's mostly genetic, but certainly that early environment with eating, and if you start to gain weight, I don't know if it triggers it or makes it, but it's certainly going to make it worse. But I don't honestly have the answer. I don't think anyone really knows yet.
Do you think you could reverse PCOS?
Well, I think that depends on what you mean by reverse.
Maybe at least the symptoms, maybe symptom management, putting everything as like you don't feel like you have PCOS, even if you have it. Like you can just live without worrying too much about all of the consequences of PCOS.
And the answer is to a very, very, very significant degree. What you see is that when PCOS women engage in lifestyle change, by which I mean regular exercise, and we'll talk about much of this, diet, fat loss, most of the symptoms tend to decrease, if not go away completely. There's actually, I think it was like bariatric surgery is at the very extremes, but when you get that, I mean, that tends to reverse almost all of this. And you see basically an elimination of almost all of these symptoms, even relatively small amounts of fat loss, 5 to 10% of current body weight, right? So if you're 75 kilos and you lose 3.5 to 7.5 kilos, you see, because what you see is a decrease in insulin, a decrease in androgen levels. The decrease in androgen levels improve things like acne, oily skin. PCOS women often have more of a male body fat patterning. They carry more fat around the midsection. That frequently goes away. Fertility improves. Like, is it 100%? Probably not. But to a very, very, very significant degree, yes, it is reversible. Now, it's not curable in the sense that once it's there are genetic changes in skeletal muscle in a piece that are never going to go away, right? It is going to be but as long as those behaviors are maintained, absolutely you can get a reversal. Like I said, all the issues with metabolic syndrome get better. All of that absolutely, absolutely improves.
Now, let me ask you something. Why inositol is so special as a supplement to perhaps reduce symptoms, improve fertility, or just by the fact that it allows you to just have a better quality of life?
Right. Okay. So this gets super complicated, and I don't even know if I could explain the details. So I'm going to give you the simplified version. So I mentioned that PCOS women are insulin resistant. Okay. So the way hormones work in the body is you got your hormone, which is like a key. You got the hormone receptor, which is like a lock, right? So you got insulin, you got the insulin receptor. So insulin binds the receptor. Now, looking at the very end of it, you see things like glucose is stored within the muscle. Insulin does what it's supposed to do. In between step one and the final step, magic happens. That's the best way I could describe it. There's a whole bunch of steps in between. And one of the problems in those intermediate steps is myo-inositol. And there's something, it's deficient. I forget the exact details, but the sort of the take-home point is that one step between insulin binding and insulin doing its job has to do with myo-inositol.
Okay.
When you supplement that basically corrects that problem.
Okay.
And of everything, and they've studied a bunch of different stuff for PCOS. The inositols, and there's another one called D-chiroinositol, which is very involved in reproduction. But myo-inositol, and myo means muscle, so it's working in skeletal muscle. It has been profoundly well studied. Like the benefits it has are absolutely enormous. Because as I was saying, that insulin resistance, whether it's being caused by elevated testosterone or is causing elevated testosterone, doesn't really matter. Because if you fix it, you improve insulin sensitivity. If you reduce insulin resistance, insulin levels go down, testosterone levels go down, and there's a good cycle rather than the bad cycle. So it has absolutely profound effects.
Do you always take it as a supplement, or can you just have it from certain foods or certain things that you can just obtain?
I don't even know what foods it would be found in. To my knowledge, it's only supplements, and you do have to take 2 grams per day. I don't even if it were found in food, I don't think you could get enough. But it is absolutely, like I said, one researcher, and I know you've got a question about metformin. Well, let's talk about metformin first, and then I'll come back. Metformin is one of the sort of first line approaches for treating PCOS, and it is a drug that improves insulin sensitivity, right? They use it to treat diabetics, metabolic syndrome. And there's a great deal of overlap. PCOS is not metabolic syndrome, but it can lead to metabolics. It's the same basic issue. And metformin has been used for decades, I think, has a number of beneficial effects. Works very similar to the inositols. You see the same benefits: improved insulin sensitivity, lowered insulin, lowered testosterone, androgen levels. It basically does the same thing. Now, metformin absolutely works, but it can cause stomach upset in a lot of people. It's just not well tolerated by some people. Now, they have compared metformin to myo-inositol to metformin head-to-head in studies. Myo-inositol works as well, if not a little bit better, without any of the negative effects of metformin. And one paper I read very recently said that, due to the negative effects that metformin can cause, they felt that the inositols should replace metformin as first-line treatment for PCOS. So metformin is absolutely not overrated. It is something like it is the primary treatment, or probably should be, for the majority of it, for the PCOS women who are insulin resistant. Like I said, there is that subgroup that isn't, but if a woman with PCOS is overweight, 95% probability she's insulin resistant. So it's not really worth even considering the exceptions, because it's such a small number.
Do you think that advice that women with PCOS are given, that they tell you, well, you have to move more and eat less?
Right.
What do you think about that statement?
Well, I mean, in the most general sense, that's true, right? But that's what we've been telling, but it's true, but it's incomplete. And it's not a terribly useful piece of advice.
It's not helpful.
Far more specifics, right? It's correct, but it's unhelpful. Exactly. Because it doesn't really give them anything beyond that. So I'll come back to diet. I want to talk about exercise first. We both know, and I'm sure you tell your clients and your listeners this, exercise in and of itself doesn't have a big effect on weight or fat loss, at least in the amounts most people can do it, right? If you can do hours per day, you can absolutely. But for the average beginner who's just starting out, the number of calories you can burn through exercise just isn't that great. And it just doesn't have that big of an effect.
Yeah.
Now, can it help? Sure. Will it improve, the proportion of fat versus muscle that you lose? Absolutely. But it's not really going to increase weight loss very much. However, exercise improves insulin sensitivity. And that's probably its major role for women with PCOS.
Absolutely.
Is being part of this overall approach to improve insulin sensitivity at the muscle, to start breaking this cycle of high insulin, high testosterone, high insulin, just by attacking that part of it. So it is beneficial. It is one of those places that the effects on insulin sensitivity are fairly short-lived, whereas a non-PCOS beginner, I might say, 3 days a week is fine, do cardio and weights. So with PCOS, I think it'd be better to try to do something daily if possible.
Is it better to do more, focus more on weights, resistance training, or cardio?
Both, actually. It looks like, and there's not as much research, believe it or not, especially on weight training. Cardio training and weight training seem to have slightly different effects in terms of addressing what's going on. So as I think you would probably recommend, a combination, probably ideal. There's also, they're still trying to kind of hash out how intense does the aerobic activity need to be? Or is interval training a good idea? And high intensity intervals can be very effective. Is a beginner going to do that? Right? You and I, we always have to ask that. I read these studies and I look at these workout protocols and I go, I was an athlete for 25 years. I wouldn't want to do that. And you're going to tell me that a beginner is no, a beginner is not they're going to quit. So that's something I would say save for later, once you sort of get a fitness base. But so regular, ideally daily activity, I think, is a big part of it, in the sense of just improving muscular insulin sensitivity. That's going to be the key to it. Now, then there's diet. So there is an idea, and it is mostly a myth, that women with PCOS have more difficulty losing weight or losing fat. And it's true and it's not true. So it's not true in the sense that when they take, we've done a bunch of research on this, they take non-PCOS women and PCOS women and put them on a diet, they lose fat at effectively the same amount, the same rate. However, there's sort of this little data point kind of hidden in the research right? Now we know that most diets, very high dropout rate, right? Just as the reality of the, and even in research, something like 25 to 30% of study subjects in diet studies will drop out. That's just kind of the standard. PCOS women show nearly double the dropout rate. So I think the better conclusion is PCOS women lose fat as effectively as non-PCOS women if they can adhere to the lifestyle change. Now, I want to really discuss this. I don't want anybody to ever hear me going, they're lazy, they're this, they quit, blah, 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 blah. Because the question, the more interesting question then becomes, why? Why is the dropout rate so much higher in this particular subgroup? And it goes back to all the things I talked about. If your body is not regulating appetite well, good luck sticking to a diet if it's not set up correctly. If you are suffering from anxiety and depression and are in stress and are prone to binge eating, good luck. And if you're not sticking with the diet and you're not seeing results, of course you're going to quit.
And if the methods, and I guess to add to your point is that if your methods are unsustainable, obviously the results are going to be unsustainable too.
There's that. There's also the question of, is there an optimal diet to treat polycystic ovary syndrome? And this has been the subject of research for like 30 years to try, or something like that, to determine like, okay, is there a better or worse diet for women that have PCOS? And a bunch of work on this. And again, in general, the answer is no. If you create that deficit, fat loss, essentially no different. And we know this. This is true in general, right? We know that if you're getting enough protein, whether you do keto or carbs or moderate carbs, it doesn't really matter. It's the deficit in the protein, right? But that again brings us back to the question, does the setup of the diet have the potential to improve adherence, to improve health markers, which frequently do change differently in these studies? And there are subtle differences, but they're there. Now, probably 3 of the most interesting papers I've read on this topic looked at increased protein intake in PCOS women. Right now, I know you have, and I certainly have, and most people, know now, like, the bodybuilders were right. You need higher protein intake on a diet. Like they were ignored for decades, and they were absolutely right. And in several of these studies, when one, I think probably the most profound one I saw, all they did was have the women like double, like 40% protein intake. It was something like, I want to say nearly 3 grams per kilo. It was a lot. It was like 140 grams of protein per day.
Okay.
The women lost, I won't get the number right, something like 5 kilos in 6 weeks or 12 weeks without restricting their calories. Because when you increase protein to that level, you automatically tend to eat less. So with that one change, just getting PCOS women to eat more protein, there was another study that even though the weight loss wasn't any different between the higher and lower protein, the higher protein intake had a bigger impact on reducing depression, reducing anxiety. And it's hard to, was it the protein changing neurochemistry, mood? I don't know. And I kind of don't care, right? I don't really care the whys other than, look, clearly this is superior. And so when you see folks, recommending the standard, 15% protein, or like, no, the research is extremely clear that you may need as much as, and I tend to pick a happy middle ground, like, 2.4 grams per kilo, somewhere in that range. I usually set it relative to lean body mass, but, so you're looking at 130, 140 grams of protein, and often that alone is all you really need. Some other studies have looked at fat type, and there's not as much work on that, but it's always the same story. Unsaturated fats like olive oil tend to be very either healthy or very neutral. Polyunsaturated fats, especially the fish oils, up to a point, tend to be beneficial. And excess saturated fats tend to cause insulin resistance and be a negative. Like it's really nothing new, but it's just like the same rules kind of apply here. Now, some of the work has shown that if you increase dietary fat, percentage-wise, to like 30 to 35%, that is also beneficial. But then we have to ask, right? If you have this many calories and you increase fat, well, something else has to change, right? Yeah. Right. So is it? And a lot of other work has found that, lowering carbohydrates to say 40 to 45% of total calories, which might be, 2 to 2.5 grams per kilo, maybe up to 3 grams per kilo. So we have to ask, like, okay, is it the higher fat? Is it the lower carbs? Is it both? Or the bigger question is, does it matter? Right?
Do you think type of carbohydrates and distribution of carbohydrates could play a big role?
Yes, and that is a separate thing. So there is research, and this is true in all domains, that are like, oh, high carb, low fat diets and moderate carb or lower carb diets have the same effect. Whenever I read these papers that are using high carb, low fat diets, they are eating mostly high fiber, low glycemic index, unprocessed carbs. That is the types of carbs people don't eat in the real world, right? So I'm not dismissing those studies, but what I'm saying is, in my experience, most people don't eat those foods. So without getting too deep into the woods, have you ever talked much about glycemic index on your podcast? Okay, yeah. So you know what the glycemic index is, and it's not really very useful. There's something better called the glycemic load,
yeah,
right? Which is the glycemic index times the total number of carbohydrates. So what you find is that, okay, if you have a certain number of carbohydrates, if you lower the glycemic index and basically eat all the carbs that nobody likes, I mean, just, I don't, you see glycemic load comes down by like 40 points. If you just lower carbs or increase fat, it comes down by like 35. So to me, in the real world, I am more a believer in, and a number of youth studies, more recent, have said, look, for PCOS women, 40 to 45% dietary carbohydrates, or potentially lower, is probably the way to go, because really it's just that way you can have a moderate dietary fat intake. Dietary fat tends to slow digestion, tends to decrease how quickly carbs are getting into the bloodstream, gives you enough room for protein, and you kind of end up, right back at 30% protein, 40 to 45% carbs, 20 to 25% fat. Like, if someone was to ask me what I thought was like the most generic best diet for most people, that'd be it.
Right? Yeah, the most balanced approach. Yeah.
Yeah, if you're a high-level athlete training 4 hours a day, you need way more carbs. And if you're severely insulin resistant and inactive, you may need to go full keto. But for the average person, that allows enough carbs, enough food variety. But yeah, certainly lowering, eating more unrefined carbohydrates and fruits and vegetables and things will never hurt. In my experience, that's not and again, I've got a very American mentality. That's not what people eat. That's not what most people eat. For me, just lowering the carbs tends to do most of the heavy lifting, and I think tends to basically have the same. So, and I think all of these things, what they add up to, because if you think about it, right, what insulin resistance represents is when you eat carbs, especially either a lot of carbs or very rapidly digesting carbs, blood sugar goes up, insulin goes up, that causes problems. Blood sugar goes down. Your blood sugar is doing this all day. That can drive appetite. That can affect mood. That can affect any number of things for women. Whereas when you balance this all out by having enough protein, which helps to control appetite and keep blood sugar stable, having moderate dietary fat, which helps with a number of things, with moderate carbs, you start to smooth all that out. And I think this addresses, in a very long answer, the fact that PCOS women have higher dropout rates, but I think a lot of that is because the dietary setups and the lifestyle modifications are not being tailored to their specific metabolic state, psychological state, personality, behavior, lifestyle, right? There's a paper way back when, I must have read it 15 years ago, and it was titled The Optimal Diet for the Treatment of Metabolic Syndrome, right? This is in the early days of that. And it said exactly what I just said. They did recommend lower protein. Protein can raise insulin, but and they were like, yeah, you're better off. You should moderate carbs to 40 to 45% and raise fat. And I'm like, it's the same story. For someone who is insulin resistant, unless you can get them to eat nothing but fruits and vegetables all day, which they won't do, most people won't do, moderating carbs addresses and if that lowers insulin, which lowers androgen levels, which helps eliminate some of it, because testosterone drives appetite. It's part of why men eat more than women. You can lower those testosterone levels. Maybe that helps appetite be in better control. Maybe, and it takes about 3 to 6 months as women see improvements in, like I said, oily skin, acne, body hair. That improves self-image or self-worth. And again, I'm just talking about, I don't want women to say that that's not what you should we're just talking about the way the world works, right? If that has these knockoff benefits to all the other effects, to me, that increases the potential for adherence. if activity, for a lot of people, doing daily activity helps them adhere to their diet. For others, it can make them go, I earned the milkshake, that thing. But for many, they tie those two together. So I think a lot of it with PCOS women is finding the optimal approach that not only addresses the health issues, the hyperinsulin, the insulin resistance, the elevated insulin, the androgen levels, but also addressing the behavioral factors that may be decreasing adherence.
I hope you enjoyed this video, and if you have any questions or any comments, please comment below and I'll be sure I'll answer to this as soon as I can.